This really is a wonderful way to support our community by working and creating, supporting programs that people in our community can access.
We look at our vision of a safe and healthy community for all. We mean all people.
But because we reach out to them, that we show up for them, that everything we do is about them, I believe that we restore hope in individuals that were easily able to find that because of their present circumstances would be hopeless.
I've been in some of those dark alleyways that they've been in. I've been in some of those dark, lonely places. I've felt that hopelessness, and I can really relate to them and help pull them out like somebody did for me.
In my job as a peer recovery specialist at the health department, I help people all day long. I know the answers, I know the resources, I've been there, I can say me too. If I can't do it, I know somebody who can.
We're not always here. We're out in the field. We're either in schools trying to promote healthy lifestyles and trying to stop something before it starts. In a nutshell, that's primary prevention.
So we're really looking at that early intervention component, which is so important because the earlier the intervention, the better the outcomes for children and families in our community.
You will hear their stories. You will understand that they had a life once upon a time, and that they are just human beings looking for what any one of us is looking for.
She never asks you why, what, or anything. She just does for you.
She's that big sister that's got all the answers because she's been there.
Today I stand before you, I am now a daughter again. I am now a granddaughter. I can be a sister to my brother and sister. I can be a friend.
Dear future me, wherever life takes us, remember you have control over your decisions.
Write a letter to themselves and think about in 5 years or 10 years where they want their future to be. If they can start thinking now, that's the dear future me part, put it down on paper.
Don't forget that it is your life, that you don't have to shoulder anyone's expectations, because the only expectations you follow are your own.
But it's a really great feeling to see families be able to get linked with the resources that they need and feel comfortable accessing those services.
It's puzzle pieces because it's just a piece of the puzzle, and that everybody working together puts that puzzle together.
Tonight I stand here and I am proud to tell you that in the next month I will be 4 years clean and sober from any mind-altering substance.
Every peer that works here has a story and has turned their life around. So recovery is possible.
When people have access to care, healthcare, behavioral health care, that supports our community in a way that creates safety for all of us. Being healthy is all aspects. It's behavioral health, physical health, emotional health, and our crisis services continuum is incredibly important to creating not only a healthier community, but a safe community.
A letter from Canada once from a mother who just said the video that we put together that she watched when her son came home from school said, "I need help, I'm using heroin," and it was because of our video. So hearing that kind of stuff, it's very rewarding. And sorry, I've been in the field for over 20 years, and it's just every day I come in and I love what I do.
If we can break the stigma of addiction and help people feel empowered and supported to seek treatment, we can really make strides in helping people overcome this problem in our community.
And every day I look at my staff and I'm amazed at the things that they do. So I'm so proud to be part of this health department, of this Bureau of Prevention, Wellness, and Recovery.
And just give some hope to individuals that this doesn't have to be your end, because this is where we are now. This is the present circumstances, but it's not the end.
Hi, everyone. Thanks for being here today. Welcome to our event. This is Key Resources in the Battle Against Substance Use and Mental Health Conditions. My name is Patricia Dorn, and I am with the Consumer Education and Advocacy Unit of the Maryland Insurance Administration. The video that you just saw is from the Carroll County Health Department, from their Bureau of Prevention and Wellness Recovery. And so big thanks to Linda Albach, who sent that video over. Substance use and mental health conditions touch many of our lives, and the state of Maryland is committed to providing resources to help Marylanders as they navigate the services that are available to them. Today, we have speakers from the Carroll County Health Department's Tobacco and Cancer programs, as well as the Maryland Department of Health, the Baltimore City Health Department, and Maryland Insurance Administration's Appeals and Grievance Unit. So just a few housekeeping rules for today. Please turn cameras off and please mute yourself if you are currently unmuted. We are going to go ahead and we're going to take all questions in the chat today. And so the questions, if you have questions, please go ahead and put them in the chat. And you can put them in at any moment that you have that question. However, I am going to be taking all the questions at the end at the Q&A session. And so after all 5 of our speakers speak today, I will be hosting a Q&A session. And just another FYI to everyone, this is being recorded today. And so with that, I'm going to go ahead and introduce our first speaker, Barbara White from Carroll County, and she's going to be talking to us about the impact of tobacco use and vaping. Welcome, Barbara.
Thank you. Thank you. So today we're going to obviously be talking about vaping. Oops, let me see if I get my slides to advance. Okay, my slides are not advancing. Okay, so just to give you an idea, we're going to talk a little bit about data, some general things about e-cigarettes and vaping, some new products, vaping and COVID, and then some resources for quitting vaping. If you look at our cigarette consumption over the last 100 years, you can see that we were climbing, and we reached that peak in 1964 when the Surgeon General's report came out linking cigarette smoking to lung cancer, and then our rates really went down. So this is just sort of a view of how it went down over, so between 1964 and 2009, it went down 58%. We had a historic low of 13.7 adults smoking cigarettes in 2018, and we've seen a similar decrease in youth using tobacco. So in 2020, the National Youth Tobacco Survey, 3.9% of high school youth reported using cigarettes. Now, however, 8.7% reported using some kind of combustible product, which might have been a cigar, cigarette, pipe, and hookah. And that's something to keep in mind with youth, is that most youth are poly-tobacco users, meaning they'll use whatever product is available, and they're not just it's not just one product that they're loyal to. So with our smoking rates going down, we saw an evolution of electronic cigarettes, and they started out in 2006, 2007 with the ones on the left, which are more, they called them cigalikes, and they actually were supposed to look like a cigarette. And then they got bigger to these pen type, looking like a vape pen. And then for a while, the big thing was the big mod box vapes. And then we started seeing the more discreet, smaller, like the blue and the jewel. So if you look at e-cigarette use among adults, according to the Behavioral Risk Factor Surveillance System of 2016, we saw a lot of dual use, which is most prevalent. About 51% of e-cigarette use among adults is those under 35 years of age, and the prevalence was highest, of course, in the 18 to 24-year-olds. So if we look at this snapshot, it shows that about 4.5% of adults are using electronic cigarettes. And when it says ESD, it's electronic smoking device. So you can see that 11% were never smokers, but they started vaping. About 30% were former smoking smokers, meaning they quit and went back to using a nicotine product with the vape. And about 59% are dual users, which means they use the vape, but they also smoke cigarettes. If you look at kind of shoot it down to 18 to 24-year-olds, we see that 44.3% were never smokers, and for 38.9 former smokers, and 16.4 are current smokers, with dual use being about 37.8%. So what really concerns us is the blue box of people who never smoked a cigarette. If you ask them, would you smoke a cigarette? They'd be like, oh, gross. No, I'd never do that. But yet they start vaping. And we've seen this in our youth population as well. So they're calling it an epidemic of youth vaping as our numbers went up, 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 up. So our National Youth Tobacco Survey shows 2019 was a peak in the gray for high school and middle school. Middle school really went way up in 2019, and we've seen the numbers come down some, and we're really not sure, is that a true trend, or are we just not asking the right question? Because you have to be very specific. If you say, do you use an electronic cigarette? They might say, no, I vape. But if you say, do you vape? They might say, no, I jewel. So we're kind of waiting for the next report to come out to see if this was a true decline, or were we just not asking the question correctly. So back to our showing our numbers for the youth, you can see that 2018 was kind of a pivotal year, and something really big happened here. So what it was is the introduction of the Juul cigarette, electronic cigarette. The Juuls were the very concealable product that gave a very powerful hit of nicotine. And what was different about it is it had something called nicotine salts. So the nicotine salts make the nicotine very absorbable. So you get a bigger nicotine hit and very smooth. So it's not harsh. If you look at the graph, you can see the yellow is the kind of nicotine hit that you get from a cigarette. And then on the bottom, the blue is what your average e-cigarette did. So it really wasn't giving you the same kind of nicotine hit, which is a lot of the reason you have those dual users out there. But the Juul most mimics the type of nicotine hit that you get from a traditional cigarette. Now, youth will tell, when we did a poll with youth, about 52% said they liked it because it gave them a buzz. Um, 42.7% said they liked the flavors. 36% said they use it for social reasons because a lot of their friends used it. And 34% said it was easy to conceal from their parents and teachers. So this idea that nicotine delivery can be changed by the use of nicotine salts has really changed the industry. And it's about this benzoic acid that they add, which changes it from being very alkaline to very acidic. So now it used to be that the Juul, at first, the Juul was the only one that did the nicotine salts, but now there's a lot of copycat type products. And you can also get your vape juices that you buy in either nicotine salt or freebase. And the difference is the nicotine salt has the benzoic acid. It's a faster absorption. You can have very high concentrations, very high strengths, because it's not harsh, and you have less cloud production, which is important if you're trying to do it in school. So the freebase, of course, does not have the benzoic acid. If you were to have a high concentration in that, it would be very harsh, and has much more cloud production. So I want to talk about some of our public health concerns regarding electronic cigarettes. So public health, we focus on public safety, preventing disease, promoting healthy behaviors. So vaping, when it came out, was perceived as safer than smoking, and a lot of people sort of extrapolated that to being that it is safe, but doesn't safer is not the same as safe. So this is one of the early ads that came out. One of the early e-cigarettes that came out was called Smoke Anywhere, and they were promising no chemicals, no smell, no anything. So we very quickly started to dispel some of those things that they were trying, the untruths that they were giving. So one of the ones was that it's just vapor, and we quickly determined that it's not just vapor; it's an aerosol, and it has volatile organic compounds, nicotine, ultrafine particles, cancer-causing chemicals, heavy metals, and some of the flavorings are problematic. There's also a variety of substances that are known to be toxic, carcinogenic, or cause disease that have been identified in the vaping liquid solutions and aerosols. And the toxicity is going to vary by formulation and device used, because some of it has to do with the flavorings, and there are like over 7,000 flavors available. We know that there is a link between vaping and cardiovascular disease because it contains nicotine. Nicotine raises the heart rate, increases blood pressure, which can lead to hypertension and other heart disease. The vapor emits a very fine, little tiny particles that are small enough to get deep into the lungs, which can cause asthma, inflammation, and restricted airways. And there was something called popcorn lungs. It's a condition that damages the smallest airways in the lungs and makes you cough and feel short of breath. The clinical name is bronchiolitis obliterans, but it was called popcorn lungs because it was first discovered in people who worked in the manufacturing of microwave popcorn, and it came from the chemical that they used to make that sweet buttery flavor. So they also use that in vape juices to make them sweet or buttery. Um, and many manufacturers have stopped using this, but that was did cause some problems. So we know there are some brain risks for youth and young adults. Nicotine exposure from any form of tobacco is harmful to the developing adolescent brain. Our frontal lobe, which is the area for executive functioning, reasoning, decision making, self discipline, and impulse control, is still developing when you are a teen and young adult. So, exposure to nicotine interferes with the development, which could lead to cognitive and learning issues. There are youth and young adults are also uniquely at risk for long-term, long-lasting effects of exposing their developing brains to nicotine, and that includes mood disorders and permanent lowering of impulse control. And nicotine also changes the way the synapses are formed, which can harm the parts of the brain that affect attention and learning. The nicotine in e-cigarettes and other tobacco products can prime the adolescent brain for addiction to other drugs such as cocaine. So we know until age 25, the brain is still growing. And each time a new memory is created, you get stronger connections or synapses. And young people's brains build synapses faster than adult brains. So, because addiction is a form of learning, adolescents can get addicted more easily than adults. So, one of the when I talk to youth, I always talk about the fact that if you start smoking at a very young age, it's going to be much harder for you to quit as an adult. So, just sort of a recap, what are the risks of vaping? We talked about toxic substances, nicotine, and how that harms the body. The devices can explode, which is not something we talked about, but it's pretty self explanatory. The fact that it's addictive, and there still are many, many unknown effects. So, we are really just starting to learn about the dangers of vaping. One of the things we've discovered is that vaping compromises the immune system, which makes you more vulnerable to things like flu and pneumonia. And this has always been a concern is that the flavored liquids labeled as food grade or generally recognized as safe for food and drinks may be unsafe when heated and inhaled. And this is an example right here. Between July and February of 2020, Over 2,800 individuals in the US were hospitalized with severe lung injury. There was many more cases that were not hospitalized, and there were 38 deaths. The CDC got involved, and they gave it a name, EVALI, which is e-cigarette or vaping product use associated lung injury. And all of these people reported using vaping products. When we broke it down, about 82% reported using THC containing products, 57% reported using nicotine containing products, and 14% reported exclusive use of nicotine containing products. So, what they were able to determine was that it was more than likely this vitamin E acetate. Um, and vitamin E acetate is used as an additive, most notably in the THC containing vape products. It's also found in many foods, including vegetable oils, cereals, meats, fruits, and vegetables. It's a dietary supplement and it can be used in cosmetics. So we know that vitamin E acetate does not cause harm when ingested as a supplement or applied to the skin. However, research suggests that when vitamin E acetate is inhaled, it interferes with normal lung functioning. The Mayo Clinic did a lot of work with some of their cases and sort of what is post evali, what does that look like? So they said the lung damage in some of the people who had become ill, it resembled a chemical burn in the lungs. Okay, new products. So it seems like as soon as we have a law or there's some negative effect of one product, a new product pops up to take its place. Um, in February of 2020, the FDA banned the sale of flavored cartridge-based electronic smoking device products such as Juul, other than tobacco flavor and menthol, because it was felt like the flavors were one of the things that was attracting youth to using these products. Now, this ban did not regulate the self-contained disposable products or bottled e-liquid for tank-based systems. So we started seeing this product, Puff Bars, and in their website it says designed to fill needs made by recent changes to e-cigarette legislation. So the Puff Bar is a disposable, so it's um, not included in that FDA ban. Um, and so there's no maintenance. You don't have to charge it. You don't have to refill it. You just puff on it to activate it. There's about 300 puffs per disposable, which is about a pack of cigarettes. And you can still get them in lots of very fun flavors, unlike the Juul, which now can only be tobacco and mint flavored. So the disposables, we quickly saw them replacing Juul in popularity among young people, and that's because of that loophole. Now, in Maryland, the comptroller banned the sale of disposables on February 10th, 2020. We know that just because it's banned doesn't mean uh, youth don't know how to get their hands on it. So we are still seeing them around. So as soon as something becomes popular, you get a lot of lookalikes. So these are a lot of Puff Bar lookalikes that are available out there, and it's the same kind of thing. It's you use it until it's done, and then you throw it away, and you can get it in the flavors. So this is a product that I started seeing right around the time when Evali was really hot, high, and they were saying your best bet is not to vape because we don't know what's going on here. So this came out as an alternate product. It's called Zyn, and it says fresh new way to enjoy nicotine. And this is a pharmaceutical grade version of nicotine salt um, that you put. It's in a pouch, and you put it in your the upper part of your lip. And then, of course, we got all of these copycat types that came out. Now, some people argue that they could be used for smoking cessation, but they're not FDA tested. And then there are concerns about youth use and self dosing. So, just a couple of words about COVID and vaping. So, we know that because e cigarette use um, lowers affects your immune system, if you're vaping, you are more likely to develop COVID, or you're more at risk for developing COVID. And during quarantine, we of course saw some changes in youth use. So we have your experimenters who are youth who are occasional users or maybe had just really started using, and we saw their use decrease. So obviously less peer interactions, less access, um, and it was a social activity, so there's not a social out there. Our regular users, their use increased. For them, boredom, maybe they're high risk youth and being at home is a stressor and they use it to cope. So we're just going to go through quickly. Um, so, what is the best method for quitting vaping? And we really don't know. We know that research shows that the best method for quitting smoking is a combination of counseling and medication, such as nicotine patch, gum, or Chantix. So, we can only guess that this would work for vaping. Unfortunately, youth cannot get nicotine products. They're 18 and up, but these are some places where they can get counseling. Maryland Tobacco Quit Line. They have tobacco treatment for all, age 13 and up. You can connect through 1-800-QUIT NOW. You can go online or you can text READY to 200-400. And they have some text-based counseling that they can do. Also, the Truth Initiative offers texting support for youth to quit vaping. And you can text READY to 88-709. There are some other things popping up, but none of it is really has any efficacy around it. So we're just sort of guessing that this is what helps. And these are some resources for parents. The Truth Initiative has a resource for parents to help their children with quitting. CDC Talk with Your Teen about e-cigarettes, a tip sheet for parents, and healthychildren.org facts for parents about e-cigarettes and vaping. And that is all my information.
Thanks so much, Barbara. That was great. Next up today from the Maryland Department of Health, we have Joanna Joasel. Welcome, Joanna.
Hi, thank you. Can you hear me?
Yes.
Okay, perfect. Thank you, everyone. Thank you, Barbara, for that wonderful presentation. Believe my presentation kind of piggybacks on that. However, the focus of the presentation today is substance use and the developing brain. And as Patricia shared, my name is Joanna. I represent the Behavioral Health Administration arm of MDH, specifically the Child, Adolescent, Young Adult Services Division. So let me just make sure I can toggle through. Uh-oh. Okay, there we go. I apologize. Okay, so for the start of the presentation, I wanted to share an oldie but goodie, probably showing my age, but hopefully this will work. Wanted to share a little clip of a video.
Okay, last time. This is drugs. This is your brain on drugs. Any questions?
Okay, hopefully I can get back to our presentation. Seem to be having problems getting back. Joyce, do I still have control? There we go, thank you. So that video itself, I think, aired back in the 80s. And it was one of those, what I call scared straight type of videos. And there we go. One of those scared straight type of videos. It's kind of straight to the point. It's a little literal, figurative as well, but it just basically kind of scares our young ones and parents as well, as far as the impact drugs would have on the brain. And when we're talking about the brain, especially as it relates to adolescents, we know that the adolescent's developing brain is something that does not solidify, for lack of a better word, until at least the mid 20s. So adolescents, that's the age group that we typically refer to as, between the ages of 12 to 17. We know that within this particular developmental period, the brain changes are complex, as well as body development, all of which can have all which can be negatively impacted by the use of substances. According to Wetherell and Tappert, exposure to illicit drugs and alcohol during the developmental period for the adolescent's brain development interrupts the actual brain development and related cognitive and behavioral functioning. I think we're having a little issue with the slowness of. There we go. When we're talking about young adults, that's typically within the age group of 18 to 25. We're aware that this particular age group experiences a number of significant transitional issues, ranging from possibly moving out of the home, moving onto a college campus for further education, going into the military, gaining employment, changes in their peer group, changes within their family relationships, et cetera. So all of these challenges oftentimes lead to experimentation with substances. And it's believed that this particular age group utilize alcohol and marijuana the most when it comes to experimentation and or actual use of substances. Once they start using in the adolescent period, it's believed that there's a likelihood that the use will continue into adulthood. So on the screen before you is just a depiction of what our brain looks like. As Barbara mentioned before, the frontal cortex, the prefrontal cortex, it really regulates a lot of the mood regulation, decision-making, and just overall logical processing, brain functionings. And again, this does not fully develop until at least the mid-20s. It's believed at least by age 25, the prefrontal cortex is fully developed. What's really driving the adolescent during their developmental process is the amygdala. And the amygdala is known as the risk or impulse control center. It's fueled on emotion. So when we're thinking of our adolescents, we think they're very impulsive. They take a lot of risks. They do things that we really don't quite understand, that doesn't really make sense. So a lot of that is really driven by the amygdala. They haven't yet formalized appropriate decision-making, problem-solving techniques at this point in their development. And then the hippocampus really is known as the hub for memory and learning, and it's still developing in the teens. So essentially the brain during the adolescent period is in an infancy stage, for lack of a better word. It's developing, it hasn't fully formed. Decisions made during this particular age group aren't necessarily the best decisions and can be very fickle as far as what they choose to do, what they choose to engage in. Peer pressure is very high during this process, again, because that central logical component of their brain, which is housed in the prefrontal cortex, isn't fully developed. So it kind of makes sense when we're talking about why this particular development period is so crucial. So as mentioned, the brain's prefrontal cortex is the last area of the brain to fully develop. It's responsible, as I stated earlier, for mood regulation, logical responses, organization, focusing, attention, impulse control. When we're thinking about that, we're thinking of our students in schools. Are they able to process what's being taught? Are they sitting still? Are they focused on what's being taught by the teachers, by their professors? Are they organized? Can they complete tasks in a logical fashion? The prefrontal cortex is also known for development of the personality. So again, this is a very crucial stage within the adolescent development period, that once the use of substances is introduced, it does alter the chemical makeup of the brain, and it does alter the overall functioning of the brain. So one of the, I apologize, one of the researchers that really studied the development of the adolescent brain, Bava and Tappert, suggested that the adolescent brain development puts this population at risk for reward seeking and risky choices. I apologize for the phone ringing in the background. So as a result of these risky choices and reward seeking behavior, the use of substances is introduced during this time period. It produces significant negative consequences within brains that aren't fully developed, again, our adolescents, our young folks, and the possibility of permanent brain damage, which is referred to as abnormal changes. But we know that oftentimes, depending on the frequency of use, the longevity of the use, that it can lead to permanent brain damage. So when we're talking about abnormalities of the brain as a result of substance use or exposure of substances, it's manifested through declined academic performance, poor peer and familial relationships, increased risk-taking behaviors to include unsafe sex, to include unwanted pregnancies, to include criminal behavior, involvement with the legal system. Juvenile delinquent cases are open oftentimes, potentially secondary to experimentation or use of substances. It also increased drug use, addiction, and co-occurring disorders. Some factors that are known to influence the relationship between substance use and the mental health problems, or the comorbidity of both, includes the age at first use. Was the youth introduced to alcohol at age 10 and has been using, ever since? Did they start experimenting with marijuana at the age of 12 and has been using ever since? How often are they using? Are we talking about a drink here and there? Are we talking about, swiping a can of beer from, mom and dad? Are we talking about more steady use? Are we talking about, consistent marijuana use? Are we talking about, cocaine use? Are we talking about partying with friends at raves, things of that nature? Frequency of use is also another factor, and of course, genetic vulnerability. When we're talking about genetic vulnerability, we're really talking about the biological makeup of the genes of that particular youth, basically the genetic information received from the parents. Was mom a substance use? Did mom use substances? Did dad use substances? Is there a family history of alcoholism or drug use? So all of these are compounded to further identify the negative impact of substances, especially on our adolescents. Now, this next section, we're just talking about the different types of drugs. So I just want to take a moment to take a look at this particular chart. And just a quick show in the chat box, if folks can readily identify what is the theme here as far as types of drugs. Are we seeing more than one particular drug reflected in the different categories? Are you surprised at some of the drugs that are identified in these categories? Mm-hmm. Yes. So someone identified marijuana, and that's exactly the point. Marijuana is reflected in all three drug categories, in the stimulants category, depressants, and hallucinogens, which is quite interesting. However, if you do a little research on marijuana, it makes sense why marijuana is identified in all three categories. So we'll talk a little bit about that throughout the rest of this presentation. So first, let's start off with stimulants. How do stimulants impact the adolescent brain or just the brain overall? So stimulants is believed to increase alertness and elevate mood by targeting the brain's dopamine and norepinephrine. I apologize, I need a drink of water. These particular neurotransmitters. So the dopamine influences your mood, The norepinephrine affects the blood vessels, the heart rate, the breathing, basically your circulatory respiratory system. And then the common stimulants that are prescribed or out in the community right now, of course, is Ritalin, Adderall, Concerta, marijuana. For those individuals who work with adolescents, we're very familiar with the Ritalin, Adderall, and Concerta because it's prescribed quite frequently to address ADHD symptoms. For the side effects of stimulants, it includes, faster breathing, higher body temperature, increased energy, increased or rapid heart rate. I'm not going to go over vaping because I think Barbara White did an awesome job just going over vaping and the concerns around our adolescents using vaping products. But I do want to just identify that with the vaping, it can be used so discreetly, it can be, hidden, that oftentimes our young ones are getting away with using it because we're not aware that they're actually using it. And as Barbara mentioned, there are so many products out there that it's kind of hard to keep track of exactly what they look like because they're constantly evolving. And it does at times seems to be targeting our young ones with the different types of flavoring that they've offered and the different marketing strategies that they've offered. So the other category that we will talk about is depressants. Depressants are believed to have a relaxing effect on the user due to its calming effect on the central nervous system and just decreased brain functioning. So some common depressants that are prescribed are Ambien, Xanax, Klonopin, Valium, Ativan, alcohol, and again, marijuana. Side effects of depressants believed to be lowered energy, slow breathing, slower heart rate, a lower body temperature, decreased brain functioning. And then side effects of alcohol, specifically alcohol misuse, include liver damage. We're talking about cirrhosis of the liver. It includes heart problems, dependence, and blackouts. For opioids, which is, we're dealing with the opioid epidemic, and then just the overall concern of our young ones using opioids, especially during this period of this COVID-19 pandemic period, the use of opioids has unfortunately increased during this time frame. Now, opioids are just one type of depressant. It's believed to slow the body down and makes the user very sleepy. Common opioids include heroin, fentanyl, oxycodone, methadone, hydromorphone, and Vicodin. Now, these opioids may be prescribed. Oftentimes, our young ones are receiving these opioids from their family, from their friends, or even their own personal medical treating providers due to a dental procedure or sport injury. It's believed that the earlier the age of the opioid exposure, the greater the vulnerability to developing an opioid use disorder. Hallucinogens, again, some of the more common types of hallucinogens that's out on the streets is PCP, we have LSD, and of course marijuana, which is now becoming more and more readily available. Just gonna skip over that for, excuse me. As far as side effects of hallucinogens, we know it's caused delusional thoughts, it causes bizarre physical motions, and of course, auditory, visual, sensory, and tactile hallucinations. So let's talk about marijuana. Marijuana has the psychoactive chemical called THC. It's what alters the mental state of the user. This is the reason why it falls into the hallucinogenic category. And there are multiple strains of marijuana out there, which produces different types of effects on the user. So the reason that it falls under all three categories is because it provides a sense of euphoria, a sense of relaxation, and heightened sensory perception. So some side effects of marijuana use include slurred speech, dizziness, slowed breathing, memory problems, poor concentration, paranoia, et cetera, et cetera. So the impact of the marijuana use on teen brain based on this pictorial, it causes problem-solving issues. There's less control of the use of motion over the use of motion, slower processing, lower verbal comprehension, and just poorer memory altogether. I'm not going to go over medical marijuana for the sake of time, unfortunately, so I'm going to skip over that. Want to talk a little bit about the impact of COVID-19 on our young ones when it comes to substance use. So one of the things that we learned about COVID-19 and our youth when it comes to substances is that there's a need for more research to better understand the emerging threats of COVID-19. One of the primary issues that came out is the inability of professionals, clinicians, to appropriately assess the problems our young ones are facing due to the various public health emergency mandates that were put in place. I know we have a rebound of our young ones being seen by primary care physicians, but we have not seen the same kind of rebound for our young ones being seen for behavioral health needs. So there's definitely a need for more research. One theme that one theme that struck with me when I was reading some of the articles is a phrase that Dr. Andrea Raby stated about the epidemic hidden in a pandemic, and that's basically was talking about the use of substances by our young ones, that it's been hidden by this pandemic, that we're not realizing the overall effects of the substances by our young folks. So let's talk about treatment. Some of the impacts of substances on the brain can be reversed if it's identified early and treated early. So there are lots of treatment modalities that are out there right now, which includes, SBIRT, which is a screening, brief intervention, referral to treatment, often used in ERs and outpatient mental health clinics. Motivational interviewing, there's a lot of harm reduction models that's being used. Of course, self-help sobriety support groups, some holistic treatments such as mindfulness and spirituality, and of course, family-based treatment models. All of these are treatment modalities that have been identified as evidence-based, with the exception of some of our more spiritual focus, holistic focus, but they've been identified as evidence-based treatment modalities that can be used to address the needs of our young ones. So I'm going to skip that for now. Within our Maryland's public behavioral health system, there are several treatment options available to our adolescents and young adults. They include outpatient programs, IOP, which is intensive outpatient, partial hospitalization. We do have ASAM level 0.5 to 4.0, as well as some non-clinical services, which is the adolescent clubhouses. And we are in the process of creating 2 new young adult recovery housing programs, one in Carroll County and hopefully another one in St. Mary's County. The behavioral health ASO right now is Optum. They are another resource for referrals for some of these programs when we're talking about IOP or PHP. So definitely a resource that you can use to reach out to them to find out more information about providers in your respective county. And then finally, for some additional resources, certainly suggest taking a look at the youth risk behavior surveillance system, as well as the portion specific to Maryland that has really great information specifically focusing on our young adults in Maryland. And then finally, if you need to reach out, these slide will be shared, I believe, by Lynn, is that correct? So definitely feel free to reach out if you have any additional questions. So thank you for your time and apologize for the technical difficulties. Thank you.
Thank you so much, Joanna. That was great. Next up, we have 2 folks from the Baltimore City Health Department. We have Lisa Parker and Rania Mohammed. And they're going to speak to us next. Lisa Parker is our next speaker. Welcome, Lisa. Lisa, can you hear me? Rania, can you hear me?
Yeah, I'm able to hear you. Lisa, are you there? I can see her thing is highlighted, so I think she's trying to speak.
There we go. She's up.
There we go.
Hi, Lisa. Can't hear you.
Yeah, your
Oh,
audio.
there you go. I think I heard you. No. You're muted. Okay. Still can't hear you, so sorry. Do we want to advance to your slides, Renia, and then she can see if she can
Yeah.
troubleshoot? All
Yeah, we
right.
can do that.
All right.
Sorry about that, guys.
Oh no, thank you so much. I'm gonna mute myself and
Okay, I think I have control. Let's see. Okay, let's see if I can start video. All right, so hopefully you guys can hear me well. My name is Ronnie Muhammad. I'm the Community Engagement Liaison at the Baltimore City Health Department, specifically the Overdose Prevention Team. And so I'm gonna go through this really fast so I can give Lisa some time to do her part. So I apologize in advance if I'm speaking very fast. But I just want to go over some brief history. So the epidemic came in 3 waves. So in the late 90s, we had an increase of deaths involving opioids due to overprescribing. And so the PDMP system, prescription drug monitoring program, was already established. But during this time, there was a lot of doctor shopping. People were easily able to access prescription medications. And then we started seeing a shift around 2010 from pills to heroin. And so with that decreased prescription access, people sought the street version, which is heroin. And in 2013, we started seeing an increase in deaths related to synthetic opioids, primarily fentanyl, which is in practically all drugs. The DEA reports that it's in 92 to 93% of all drugs. So cocaine, heroin, you're likely to find fentanyl. And then prescription medication, along with the presence of fentanyl, has led to an increase in deaths across the US. And Baltimore City actually saw a 271 increase in fatal overdoses between 2013 and 2019. So fentanyl in the drug supply, again, it's very dangerous. It's 50 to 100 times more potent than morphine. And in 2018, in Baltimore City, out of the 814 opioid-related deaths, 758 of them involved fentanyl. So that's 93% of the total death rate. So that goes to show how dangerous and prominent fentanyl is in the supply now. This is what's considered the lethal dose of fentanyl. So about 6 to 7 grains of salt compared to a penny. So it's very small. And other states are even reporting that dealers are fully pressing fentanyl to look like Percocet or Oxy when it's 100% fentanyl, which is obviously playing a part in the amount of overdoses we are seeing in the rise. This is a quick graph comparing all intoxication related deaths in the state of Maryland. So it shows all Maryland jurisdictions. And you can see in the far right, Baltimore City is disproportionately affected by the crisis. 914 deaths in 2019, and the second being Baltimore County's the border, so 350. But just looking at the numbers, you can see that Baltimore City is disproportionately affected. Some quick OOCC data that was released in 2020. So this kind of just shows the breakdown across fentanyl, heroin, and prescription opioids. And so fentanyl being in that blue, continuing to increase, and we are seeing a drop in heroin and an increase in opioids, prescription opioids. And then when we look at the age distribution, it's mainly with older folks, and so people over the age of 50 that fatality rate has increased. And then we saw that people under the age of 25 saw significantly fewer opioids. In terms of gender, this has stayed pretty much true consistently throughout the epidemic. Males taking majority of opioid-related fatal overdoses. And so that's the breakdown. And then with race and ethnicity, you can see the breakdown comparing 2019 and 2020. So this at 56.7%, and then 39.1%. Sorry, I'm going through this pretty fast. In terms of overdoses and naloxone, so when somebody is having an overdose, too many of those opioids are attaching to the brain receptors, stopping that person's breathing. And when naloxone is administered, it temporarily knocks off those opioids because it has a stronger affinity, allowing that person to breathe again. And so it takes 1 to 3 minutes for this to become effective. That's why you should wait that time before you try to give someone else another dose. And it will only block opioids. So if that individual is also under the influence of cocaine, ecstasy, or any other drug that is not an opioid, it won't affect it. So they will still be high from that drug. Recognizes the signs of an overdose. So the most obvious will be that person will not wake up. They won't respond to your voice or touch. Breathing is soft or non-existent. Others have reported hearing a strong gurgling sound. And that's as a result of that person trying so hard to breathe. Fingernails and lips are turning blue or gray, slow heartbeat, cold, clammy skin, and their pupils are very small. And others have also reported seizures. So administering naloxone, I'm going to go over this really quickly. So you want to try to wake that person up. And the way that we tell people to do that, just do a quick sternum rub. So ball your hand in a fist, and then this area here, just rub on there really hard for like 5 seconds. It's pretty painful, but it's effective. And you want to call 911 immediately, give them your location, let them know that somebody is unconscious, they aren't breathing. And then you want to administer naloxone. Wait that 1 to 3 minutes. If they need another dose and they haven't responded to that first one, you want to give them another one. Again, wait that 1 to 3 minutes. If you don't have any more and you require more, hopefully EMS is on the scene at that time and are able to administer more naloxone. Rescue breathing. This is, the naloxone is what saving that person's life, but this is encouraged, and people do say that this is very important. I know that right now with the COVID pandemic that a lot of people might be uncomfortable with this, but the recovery position is really important. That person is going to be going into automatic withdrawal. Same like if somebody drinks too much alcohol, you don't want to leave them on their back because they might vomit and choke. So these are some of the other symptoms that someone can experience after reversal of an overdose. These are some of the other symptoms. So a lot of the times they'll be very irritable, confused after. And after it's administered, it will only block the opioids for 30 to 90 minutes. And so in this time, it's temporary. It'll allow that person to breathe again. However, after that, that person doesn't have to take any additional drugs. Those same opioids that were in their system can jump right back on those brain receptors, causing that person to overdose again. So it's very important to monitor that individual after their overdose. If you don't know them, and it was just somebody that was random, we encourage people to stay with them until EMS arrives. If not, place them in that recovery position, and then hopefully EMS will take care of it and transport. So not going to go into too much information in terms of treatment for the sake of time, but medication-assisted treatment, the 3 FDA approved medications, methadone, naltrexone, and buprenorphine. They assist by suppressing opioid cravings, allowing their clients to focus on their individualized recovery. And managing in their treatment is the bigger plan to manage their symptoms. So I'll go over that as well. These are the breakdowns of the different medications. So not going to go into too much in detail, but these are all, you can all get them at an OTP or a doctor or pharmacist. Some misunderstandings of MAT: it does not replace one addiction with another. Addiction is defined by cravings, compulsive drug seeking, continued use, despite negative consequences. And individuals in successful treatment and recovery no longer experience these symptoms. But relapse does not mean that treatment has failed. And so a lot of the time people are going to relapse. This is a lifelong, recovery is a lifelong process. Managing and treating your addiction is a lifelong process. And so relapse rates while in recovery are 40 to 60%. And an overall treatment, an overall treatment, just this is almost over. It also is going to touch on other combinations of treatment and services. And so that could be mental health services, recovery support, peer support. Recovery and managing your addiction is based on every individual patient. And so it should be person-centered. And MET is not the only option. So MDH kind of already covered other options. Acupuncture has been talked about. I'm sorry, I'm seeing a lot of questions pop up. But yeah, it's not the only option, and it's individualized. And then reducing stigma is also very important. Addiction is a chronic disease and should be treated as any other chronic disease. And so replacing stigmatizing language like junkie or addict with person who uses drugs is important. And thank you so much. I'm gonna go really quickly go back.
And any additional questions that come into the chat, I'll ask during the Q&A.
Okay, thank you so much.
Thank you, Melania. I again apologize for the technical difficulties. Rania pretty much covered a lot of my presentation as well as Joanna. So basically, I'll just do a short review of what we've already talked about. And I'm not sure if I can advance the slides. Am I able to do that? Can you hear me first of all?
Yes.
I think you have control, Lisa. So you can try clicking on the screen or using the arrow.
All right, so as we already discussed that addiction is not a moral issue or a personal weakness. People don't always understand why, how someone becomes addicted to drugs. A lot of times they make the mistake that it's a lack of willpower or that it's a moral issue. In reality, addiction is a complex disease that changes the structure and how the brain actually functions. Addiction can be characterized by drug seeking and use that is compulsive and it becomes very difficult to control. Most drugs affect the brain's pleasure system. It causes a euphoric feeling in the body, and as that becomes more consistent in the body, it becomes overflowing to the brain and causes the brain to have more dopamine present in the brain than what would happen in a normal brain. In a normal functioning brain, the pleasure system motivates a person to repeat behaviors that make them feel good. In somebody's brain who is struggling with addiction, they repeat the behaviors of using the drug that makes them feel good or that increases that amount of dopamine that is in their system. That surge of dopamine in the pleasure system reinforces those unhealthy behaviors like substance use and again leads people to repeating that negative behavior to seek that pleasure that they get from using those substances. And one thing that we always like to share when we're talking about substances and to make it a little more understanding for people who still don't understand addiction as a brain disease, we also have to look at some of our everyday behavior is low grade addiction. If you are someone that has to have your caffeine in the morning, if you gotta have that first cup of coffee to get started, if you have to smoke that cigarette, if you have addiction to chips or shopping or any of those little things that make us feel better, some of those things are pleasurable behaviors and can activate the dopamine in our brain. So these are things that we repeat. So while those are low level controllable addictions for somebody that's using a substance, this is on a greater scale of addiction. So the who and why of addiction, again, I believe Joanna spoke about this. Development and genetics play a big role in people developing addictive behaviors, and environmental factors are critical to the developmental stages in a person's life. While taking drugs at any age can lead to addiction, as was stated earlier, the younger a person begins to use drugs, the more likely they are to become addicted. Mental illness also plays a role in that. For some people dealing with mental illness, there is an increase or an increased likelihood for them to become addicted to substances as a way to escape those feelings of depression, to escape feelings of trauma that they may have experienced, and to manage just the everyday life that they may be dealing with that may be causing them to interact with their families in a negative way, with their social networks in a negative way, or just them having a hard time dealing with life, period. So the cures for most chronic diseases, addiction addiction, there are treatment options, and Rania and Joanna did a great job talking about some of those options. People who are recovering from addiction will always have some risk for relapse, but research does show that combining treatment and behavioral therapies and tailoring that approach towards addressing any co-occurring medical or mental health and social issues can lead to a more successful recovery period. So we have to remember that there is no one size fits all cure. That a lot of times treatment involves changing deeply rooted behaviors, and relapse doesn't mean that treatment has failed. When a person is recovering from addiction, relapse is always possible, and it indicates that that person needs to resume treatment, that maybe those treatment modalities need to be modified, or they need to explore other treatment options. And again, while treatment is a normal part of recovery for some drugs, it can be a very dangerous process, even deadly. If a person stops using abruptly, or they stop and they go back to using because their tolerance level has changed for that period that they were not using drugs, they can actually go into an overdose, or they can experience some negative side effects because of that. And so, just quickly, because I'm getting a 2-minute warning, again, what we've learned from our conversation is that, again, we don't ever want to look at substance use as a moral judgment. We want to ensure that when we're talking to our clients in the community, that we take a more harm reduction approach towards providing services, and that is meeting them exactly where they are, celebrating their small accomplishments, whether they go from using 3 times a day to 1 time a day, that's actually an accomplishment for somebody that's struggling with addiction. We want to be mindful of the stigma around addiction. And again, we want to also make sure that we're not just using one type of treatment as a method to cure somebody or to treat somebody dealing with substance use. Any treatment program needs to be tailored towards that client's specific needs, because everybody is coming from a different place of addiction. So we need to be mindful as we're providing services, as we're linking clients to resources, and even as we're engaging the community, we need to be mindful to share all the different modalities of treatment, but also to be mindful to let people know that, again, this is not, again, a moral shortcoming or a lack of judgment or somebody not being strong enough to deal with something. But sometimes life issues happen and people use what they have, especially during the pandemic, with a lot of isolation happening, people losing their jobs, people not having a normal sense of life over the last year. We are seeing an increase in people experimenting or using drugs as a coping mechanism. So we just want to be mindful of that, and again, encouraging to our community and understanding of it. Thank you.
Thank you so much, Lisa. And Rania as well. Thank you both. Last but not least, up today, we have Lewis Butler with us with the Maryland Insurance Administration from the Appeals and Grievance Unit. Welcome, Lewis.
Good afternoon, and thank you for the opportunity to be with you today. I'll be speaking about from the perspective on behalf of individuals who currently have insurance, who are covered by insurance. This aspect of our presentation deals with how the Maryland Insurance Administration can assist consumers that have been denied substance use or mental health illness treatment. Okay. Types of complaints the Maryland Insurance Administration review has to do with improperly denying or delaying payments of all or a portion of a claim, improperly terminating your insurance policy, raising your insurance premiums without proper notice, making false statements to you in connection with the sale of insurance. So what we are here, the Maryland Insurance Administration, we are here to assist you in those regards. So it's important. The Maryland Insurance Administration is a state agency, and the MIA license, we regulate licensed insurers and insurance producers, examines the business practices of licensees to ensure compliance, monitor solvency of insurers, reviews and approves insurance policies, review insurance rates, and we investigate consumer and provider complaints and allegations of fraud. Types of complaints the MIA cannot review, and that's primarily self-funded or self-insured plans, medical assistance, Medicaid, Medicare and Medicare HMOs, federal employee health benefit plans, uniform services, employee health plans, and contracts issued or delivered to the policyholder in another state. So if your health care provider tells you that a certain service or medication is needed, but your health insurance carrier or HMO disagrees, you have a right to appeal that decision. And this is a very important portion. What we're talking about is the health appeals process. Many individuals simply do not take advantage of this. And the point here is denials may include a claim denial that is this is where your carrier or HMO has denied payment for a service or medication that was provided. An authorization denial that this is when a medication or treatment requires a referral or prior authorization from your provider, but this authorization has been denied by your insurance carrier or HMO. You were approved for a lower level of care than asked for, or you believe the in-network or approved provider is too far away or the wait is too long. You received an approval for fewer visits than your provider thinks you need. You are entitled to a written denial unless you or your provider agrees to an alternative care plan. And this written denial is important because it can come in the form of an explanation of health benefit. You'll often hear the term EOB, or a notice of adverse or a notice of grievance decision letter. In these three documents, they will provide you with the basis for the carrier's decision, who made the decision, and your right to appeal. So typically, it'll provide you with who to contact with your insurance company, and it will also provide information regarding the Maryland Insurance Administration and the Health Education and Advocacy Unit. The written denial explains how to file an internal appeal to your health insurance carrier or HMO, as well as how to file a complaint with us. If you have any questions about filing a health insurance or HMO complaint, or you have a denial of benefit that involved an emergency, this is important, please reach out to the Maryland Insurance Administration at 1-800-492-6116. That's 1-800-492-6116. To start, how to appeal or obtain a pre-authorization. To start the process of obtaining authorization for an inpatient admission for mental illness, emotional health disorder, or a substance use disorder, call the number on the back of the patient's health insurance ID card. So most individuals who are covered, all individuals who are covered by insurance, they are typically issued an ID card. That ID card will provide information in terms of who to contact and what steps, the next steps. So it's very important to get that information because that information is contained in the on the ID card. The insurance company will ask what facility you would like to use for the patient and or what treatment is required. The insurance company will tell you what documents they need in order to make the determination about coverage. If a patient is in imminent danger or self to others and the determination is made by the patient's physician or psychologist and a member of the medical staff of the facility who has admitting privileges, then a health insurance company cannot deny the first 24 hours of an admission based on medical necessity. Notify the insurance company as soon as possible. Typically in an emergency, time is of the essence, so you want to move as quickly as possible. For an emergency inpatient admission for treatment of a mental illness, emotional health disorder, or substance use disorder, the insurance company must make a decision on whether to pre-authorize the treatment within 2 hours of receiving the requested documents. Again, time is of the essence, so as soon as the carrier has the requested information, the clock begins to tick. If the insurance company denies the request for an admission, call the Maryland Insurance Administration, again at 1-800-492-6116. The MIA is also available 24 hours a day for complaints and emergencies when care has not yet been rendered. In an emergency, the MIA will make a decision within 24 hours. Pausing here, the administration we have on-call investigators after hours and during weekends and holidays. So this is something that I really want to effectively communicate to the viewers today, that the administration is available 24/7 in medical emergency cases. Prospective care, patient is awaiting care, in need of care. We are here to help in that regard. If the MIA does not regulate the health insurance plan, your complaint will be sent to the agency that does regulate the plan, or we will reach out to you to get authorization to send your complaint to the appropriate regulatory body. And this point is very important. An insurance company is not allowed to retaliate against a provider for filing an appeal of a denial with the insurance company or the complaint with the MIA. And that's largely because carriers are required by law to have what is known as an internal appeals process. That internal appeals process is designed to review those sorts, the sorts of appeals where the member's request for a particular medical service has been denied. The next step would be for the member to avail themselves of such. And then if the carrier continues to uphold their position, which means in Maryland, it's just 2 denials. The carrier issues its initial denial. You receive that in an EOB or an notice of adverse decision letter. You review that, you appeal, or because you've been aggrieved by that determination by the carrier, you appeal that decision, and the appeal information will be contained in the EOB. How to file the appeal will be in the EOB or the notice of adverse decision. If the carrier, after reviewing the denial, if they continue to uphold their position, that at that point you have now exhausted the carrier's internal appeals process and you have the right to come and file your complaint with the Maryland Insurance Administration. The good thing about the carrier's internal appeals process is that the appeal is reviewed not by the same person that made the original decision. So that's a very important point to make here. And I have to say, pause, that this is an aspect that a lot of people, members that are covered by insurance, they simply just don't take advantage of. Once you've exhausted the internal appeals process, now your matter is ripe to come to the Maryland Insurance Administration for further investigation. Also, in the adverse or the EOB information that you receive, I earlier made reference to the Health Education and Advocacy Unit of the Office of the Attorney General of Maryland. They can assist with filing an appeal and a complaint. And they can be reached at 410-528-1840 in Baltimore or 1-877-261-8807. Pre-authorization may not be required in certain circumstances. An insurer, nonprofit health and service plan, or HMO that provides coverage for substance use disorder benefits or prescription drugs may not require pre-authorization for prescription drugs used for substance use treatment of an opioid use disorder, and if the prescription contains methadone, buprenorphine, or naltrexone. Lastly, there's some resources that we have here. I want to make certain that everyone understands that, again, the Maryland Insurance Administration is here to help, and we look forward to hearing from you in the very near future. Thank you again.
Thanks so much, Louis. So this is thanks for all the great information from all 5 of our speakers today. And this is gonna begin the Q&A session. I'm just gonna go ahead and start with the first question that was submitted to me. And I'm just gonna read the question aloud. If you can take the question, if you believe that it is to you, that would be great. And I know a couple of them got answered here and there, so I apologize if I repeat a question that's already been answered. One other thing, if you have other questions during this Q&A, continue to submit them into the chat. And it's already 2:23, so I do think that we'll probably go just a few minutes over 2:30. Just FYI, that is a possibility. So I'm going to get started with our first question that came in. If you live in the city, can you come to the county for detox? Do you have to have insurance? Is there anybody available who can answer that? All right, so I can come back to it, or
Patty, since we don't have anybody from Baltimore County's health department on the line, probably no one is going to be able to answer that particular question.
Yeah, Veda, that I can go ahead. Oh, go ahead if someone else has something to say.
I was gonna say, just based on experience that we've had with clients at our mobile unit with Syringe Exchange, when we've had clients that requested treatment outside of Baltimore City, we've worked with those local health departments or whoever those health agencies are in those surrounding communities, and they've been accommodating to us making those referrals. So I don't know if that's a set standard of practice, but we've been able to work with the local health departments and even with those treatment programs directly, and they've accepted our clients outside of the county.
Okay, so that would be a path?
Yes.
Okay, all right, great. And Veda, if you want me to follow up more, please just say so in the chat and I can follow up after the event itself. The next question, and sorry if I pronounce this wrong, but why is Vivitrol not paid for by insurance when methadone and Suboxone are covered? It seems Vivitrol is less likely to be abused. Currently must pay out of pocket. If there's anyone who can comment on that, I don't know if there is, but if there is. All right, and if there's not, Debbie, I will go ahead and figure out a way to get into contact with you. If you want to send me contact information, that'd be great.
Yeah, for that question in particular, I would have to look at why to answer that question.
Okay, thanks. Thanks. Sorry, I'm scrolling through the chat to find questions. James asked how, oh, and I know you did reply to this. How long does naloxone stay in your system? And Lisa, you said up to 90 minutes. I don't know if you want to say anything more about that.
No, and I think Ryan covered that. Typically 90 minutes. It usually works pretty quickly. And as Ryan said, if someone has multiple opiates in their system, some opiates can stay in the system up to 24 hours. So when we're doing overdose awareness and education, we do try to encourage people to go seek medical help. And if they can't seek medical help, we do ask somebody to try to keep an eye on them because they do run the risk of another potentially fatal overdose. So again, 90 minutes to about an hour is the estimated time that it'll continue to work in the system.
Thank you. The next question is, methadone is addictive. How long should they use this treatment?
So this question, it really depends. It kind of goes hand in hand with the question below. But methadone can be addictive, but like Lisa mentioned in the chat, it is a FDA approved medication to treat opioid addiction. And so that person, when they're prescribed methadone, they're prescribed a certain dose. And so they have to follow that, what the doctor says to reduce that risk of abusing that medication. But it is helpful. It's proven to be successful in helping people maintain and reduce those opioid cravings and symptoms of this withdrawal as well. And it does block those euphoric effects of the other opioids. I don't know if that answers the question.
And if you had the question and you don't get it, you didn't get the answer that you were looking for, or just go ahead and ask another question in the chat. And then James asked, is it addictive? If so, what is used as a treatment for it? I guess he means for the addiction from methadone.
So yeah, it's used to treat opioid addiction, help suppress opioid cravings, like I've mentioned. And I forgot to answer the other question. How long should they use this treatment? So this really depends on the person. The length of time for methadone treatment is typically within the 12-month period, but some patients may require treatment for years. And so, like I said, this is a lifelong process. And so a lot of people do stay on the medications for most of their life.
Thanks. Next question got answered. All right. I don't know if this is a comment or a question, but I'm going to read it. In my experience, clinics are less likely to step individuals down off of methadone, even at the individual's request, except when the individual's insurance stops paying. Methadone programs are also referred to as methadone maintenance programs. It often isn't clear how long methadone is medically useful. In part, it is a business. I don't know if anyone wants to comment on that.
That is a challenge that we see with a lot of our clients and a lot of the community members that we work with. And because of that, we're seeing a lot of, again, the population that we work with turn away from methadone, and they're actually seeking out more Suboxone or naltrexone versus methadone. So it does, there are some good methadone programs that are monitoring and don't keep their clients on that form of treatment for an extended period of time. But I think someone did say in the comments, if it's monitored properly and it's methadone along with other mental and behavioral health, case management, and other resources combined, it can be an effective way to help somebody get off of their addiction or treat their addiction to opiate substances.
And we did have somebody comment, methadone clinics are a business and are highly regulated to treat individuals suffering from an opioid use disorder.
Patricia, if I may go back
Hey.
to that Vivitrol question. So I
Yes.
just did a quick search on Optum's website under their their fee schedule for substance use. Vivitrol is listed as a covered medication. So I'm wondering if the individual who had the question could potentially follow up with Optum to maybe tease out that particular issue if the clientele they serve have medical assistance.
All right.
And I can plug in the link to that fee schedule in the chat for folks to follow up.
That would be great. Thank you so much. Really appreciated that. I have a question just asking if the session is being recorded and will we be able to watch? The session is being recorded. It's still, the Q&A part is being recorded as well. And you will be able to see it on our website by the beginning of next week.